Good evening. My name is Joe Byrne. I'm the director of the School of Health Administration at Dalhousie University. Thanks very much for taking time off on what looks like a glorious evening, so I'm very impressed that you're able to come out for this very important talk. We have a little bit smaller group than we had previously. It's no way reflecting the importance of the topic nor the impressive speaker tonight. I think there are, from my understanding, several other major events going on in the city tonight, one including the Poverty and Health, which is a large forum tonight. I think a lot of folks who may be coming out normally here are looking at that particular talk. As I mentioned to Neil earlier, chances are there's a high percentage of those who may have had some medication issues, but they'll hear from you and friends as well from this talk, hopefully. This series we started this year, 2008, and it's an important one, we think, because it helps to educate the public about very important issues about you, which means it's about your health. And the series is called Excellence in Health Series, Tomorrow's Thinking, Today's Care. So these talks are really designed to start making us think differently about our current health care and how we may approach health in the future to ensure good welfare and well-being in the population. Tonight we have the pleasure of having Dr. Neil MacKinnon make a presentation. Neil is currently Associate Professor and Associate Director for Research at Dalhousie University College of Pharmacy. He also holds cross appointments in the Department of Community Health and Epidemiology, as well as in our own school, the School of Health Administration. As way of brief background, Dr. MacKinnon received his Bachelor of Science degree in Pharmacy from Dalhousie University. He continued on his studies and finished the Master of Science in Hospital Pharmacy at the University of Wisconsin, where he also completed his residency. From there, he moved on and completed a PhD doctoral degree in Pharmacy Healthcare Administration from the University of Florida, and there he also completed his research fellowship. I went through Dr. MacKinnon's CV, which is fairly impressive, takes up a good part of one's afternoon. So what I'll do is just really highlight a few key points here. This no way represents his impressive accomplishments. Professional affiliations are many, but to highlight, he's with the Association of Faculties of Pharmacy of Canada, the Canadian Pharmacists Association, and Canadian Society of Hospital Pharmacists. Awards and honors, indeed, are quite numerous. To highlight a few of those, in 2008, he was a recipient of the Canadian Society of Hospital Pharmacists Innovation in Safe Medication Practices Award. In 2007, he was named Harkness Associate. Most of us are not aware of this particular award until we actually go on to Google and check it out, but this is a highly prestigious award that's funded by the Commonwealth Fund and the Canadian Health Services Research Foundation. To highlight the importance and impressive accomplishment that Dr. MacKinnon has achieved, he was only one of 13 worldwide that were named as a Harkness Associate. 2006, Dr. MacKinnon was named a Fellow of the Canadian Society of Hospital Pharmacists. And prior to that, 2001, 2003, he was named the recipient of the Jesse I. McKnight Award for Teaching Excellence. He's also has done a lot of work in terms of consultation in the area of health. He's the lead author with Health Council of Canada Report on Drug Policy in Canada, member of the Medication Advisory Panel for Atlantic Blue Cross, and reviewer for numerous journals and granting agencies, not the least of which is the prestigious New England Journal of Medicine. Dr. MacKinnon, in addition to his consulting and impressive teaching skills, has a rather impressive array of research skills. Currently, he has been funded in the order of $2.5 million in research funding, and my understanding is that there are several other major grants under consideration valuing approximately $3.5 million. Dr. MacKinnon is a very busy individual, not only at home, but of course professionally. He's presented over 130 scientific and professional meetings. He's published over 80 papers. He's edited 2 books, one in 2003 entitled Seamless Care, A Pharmacist's Guide to Continuous Care Programs, And last year, 2007, he edited a book called Safe and Effective, relating again to safety issues related to medication and healthcare. Currently, Dr. MacKinnon is writing a new book aimed for the public, and he's doing that with a local physician. So without further ado, I'd like to present to you Dr. Neil MacKinnon.
Thank you, Dr. Byrne. I guess you can go home now. That's the end of the person. I'm just kidding. Again, just wanted to thank you for coming out this evening. Can everybody hear me okay? I'm not wearing a microphone. Actually, I am. This is a kind of a secret microphone. We're being recorded for video purposes, or I am anyway. You're not, so you don't have to worry about that. So this is for the microphone over there. But again, I think this room is we're a small, intimate group, right? So I think we'll have lots of fun tonight. Again, just wanted to echo Joe's words of welcome to you, and just want to thank you again for coming out. The first thing I'd like to do tonight is provide you the findings of perhaps the most important study of your life. Okay, now this actually is a fake study, but it was actually printed in the top medical journal in Canada called the Canadian Medical Association Journal. And this is the study. It's about falling asleep in lectures. Okay? So I'll kind of walk us through this. First of all, how they define a lecture is basically a means of transferring the notes from the speaker to the notes of to the pages of the audience without going through the minds of either of us. So after this, if you say "great lecture, Dr. MacKinnon," I'll know what you really meant. Okay, so you don't have to say that. You'll also notice that in this prestigious publication, they had an interesting graph. And along this axis is the duration of the lecture. You can see from 0 minutes all the way over to 40, and we're over towards the end tonight. And on this axis, number of what they call Noels, nodding off events per lecture. Okay, and some of probably the more astute of you might have already noticed the shape of the curve, right, of a sleeping man. Hopefully, again, I'll be watching to make sure that's not you folks tonight. And you can see that basically as the lecture gets longer, the number of Noels increases. Okay, so you are at higher risk for falling asleep. The authors actually go a step further, and they actually present risk factors for falling asleep. So I thought I'd just review these tonight with us to make sure we're not too much at risk for falling asleep. The first one is dim lighting, and I think we're okay here. We've got quite a bit of light coming in, so that's not a risk factor. Warm room temperature. Is it warm? Okay, so that perhaps is a bit of a risk factor. Comfortable seating. Now, those are padded chairs, so I mean they're not huge, but they're padded chairs. Poor slides, not a problem, so we don't have to worry about that. Failure to speak into a microphone. Again, it's a small room, we're okay. Early morning, not an issue. The next one, though, after a meal. I'm guessing how many folks just had dinner within the last 2 hours? Okay, so you're at risk. So I'll be watching you, those of you who put up your hand. Monotonous tone. Now, I have been accused of a lot of things in my life, but not having a monotonous tone, so I think we're okay there. The next one's interesting. Tweed jacket. Okay, tweed jacket. Now, I think as professors, often you associate professors wearing the tweed jackets, right, with the patches on the elbows. And I do have to admit that, yes, as a professor, I do have the mandatory tweed jacket in my closet, but I did not wear it tonight, so I think we're okay there. Losing place in lecture might happen. And the last one, which wasn't in the original study, but which I've added, listening to a presentation from Neil. And you can be a judge of that or not. All right. Well, more seriously, I guess we do have some serious content to cover tonight as well. And what I've really kind of organized are 4 what I call outcome expectations. Basically meaning these are 4 kind of key things that you can expect to get out of our time together this evening. The first we'll talk about how bad is the problem, talking about the problem of medication errors or medication safety. Secondly, we'll then talk about what's the cause of this problem. So given that we have a problem, again, what is the source of the issue? Next, we'll talk about, on a positive manner, what can be done to fix the problem. And then finally, really as a personal take-home for each of you tonight, we'll talk about how you can personally reduce your risk of experiencing a medication error. And then after that, Dr. Gray will have a few comments, and then we'll open it up for questions and answers. All right, so starting with the first question for the night, how bad is the problem? Now, professors love quizzes, right? Love exams and stuff. So you thought perhaps you could get away tonight not having an exam, but that's not the case. Now, this is an easy one, and I won't embarrass anyone by making you put up your hands. But here's the quiz. A presentation with the phrase medication error in the title. A, puts me to sleep. And we already covered that, right? So you're not going to fall asleep tonight. B, causes me to have a panic attack. C, causes my mind to wander. Or D, makes me want to hear what Neil's going to say. Of course, the right answer is what? D, right. Okay, all right, a good group tonight. I think we've got a good group here. So D is the right answer. All right. Let's look at medication use in general. And really, one way to describe it are three different sides of medication use. The first really is the good. And basically meaning that drugs effectively reduce or resolve symptoms, they can cure disease, and they improve quality of life. And I realize that in tonight's presentation, a lot of it will be focusing on bad things with medication use, medication errors and other problems. But really, the point is we're not trying to scare you tonight. If you're currently taking medications, I don't want you to stop. There is certainly a lot of good for medications. If you think of things formerly that perhaps were done via surgery, maybe like ulcer therapy, that basically now we treat most ulcers with medications, very simply. So there's a lot of good with medications, and I don't want us to lose sight of that this evening. But however, there is the bad, and again, we'll be focusing a lot of this tonight, that adverse consequences of medication use abounds, and a lot of it's preventable. So some of it is not preventable, meaning that we know with any given drug that anybody takes, we know that there's certain side effects, right? Whether it's rash, nausea, whatever it is, right? And there's not a whole lot we can do about those. Those are properties of the drugs themselves. However, there's also a lot of things that are preventable, that we can do things differently to stop bad things from happening. And a very conservative guess, if you had to kind of look at the medical literature, probably at least half of the bad things that go wrong with medications are preventable. All right, so we've got the good, the bad. What's left? The ugly. Today we're going to call that the cosmetically challenged in today's politically correct world, so we won't use the word ugly. But basically it's going to take a lot of work to turn the medication use system around. Fortunately, we know how to do it. Now, I did want to present a couple of warning statements with tonight's presentation. Hopefully you won't leave the room once you see these. The first is that we're going to focus primarily kind of on the bad news first. Basically, again, looking at how serious this problem is. So my point, again, is not to make you leave here depressed this evening, but I think in reality we need to focus on some both national and regional studies which have really described the magnitude of the problem. And also, the warning labels, it may cause some discomfort. For those of you who take medications, the pharmacists put those little stickers on them. We call those warning labels. And this presentation tonight perhaps should come with a warning label. Again, meaning that, again, this is for some of the talk tonight, it's not a pleasant subject. We're talking about bad things that happen to good people. So I just wanted to make sure that you're okay with those warnings this evening. All right, well, here's a picture of a pharmacy, probably about 200 years ago or so. In some ways, pharmacies haven't changed a whole lot. Maybe the dress is a little different now, but in some ways, we still have the counter, right? We still have prescriptions. I have a quote from this time. It's probably from someone that you may know, Thomas Jefferson. And what Thomas Jefferson said in 1807 is that the patient treated on the fashionable theory sometimes gets well in spite of the medication, right? In spite of the medicine. And I think we would say that's probably still true in 2008. Again, there are times where perhaps the medication wasn't optimal, it didn't do its job, and yet people still do okay. I have another quote that even goes back further. This is from King Solomon, and he says, "A merry heart does good like medicine, but a broken spirit dries the bones." Okay, so again, the fact that we realize that medicine has been used for a long time. Certainly the medications we use today, in the most part, are quite different from in the past, but certainly medications have been used for a long, long time. This is a more modern situation, and I'll read it at the bottom for those who can't see. It says, "I feel a lot better since I ran out of those pills that you gave me." Okay, so probably a little bit more modern situation. All right. I'm being a mean guy tonight. Here's another quiz, okay, for those of you. Maybe we could kind of call this Jeopardy or something tonight, or a different game. Adverse drug reactions is the blank leading cause of death. Not just for me, I'll get people to put up their hands. How many people think that adverse drug reactions is the 4th leading cause of death in Canada? Okay, so maybe about 4 or 5 of you. How many people think it's the 14th leading cause of death? So probably more, maybe about half. The 24th? So 2 of you. And the 34th. Anybody for 34? Maybe 1? Okay. Oh, and those two young folks in the back there. Okay. That's good. They're playing along too. That's good. The answer actually is the 4th. The 4th leading cause of death after heart disease, stroke, and cancer, adverse drug reaction. So that really shows the significance of this problem. Now, if you think about kind of awareness of cancer, right, of stroke, of heart disease, most people are quite aware those are serious conditions, right, that we need to treat. But adverse drug reactions, the 4th leading cause, perhaps not quite as much awareness about adverse drug reactions. So how big is the problem then? Well, you might have guessed it's a fairly large problem. These are a few certainly a few other studies that echo that point. There was a group in the United States called the Institute of Medicine. They had a report that was released in 2006. And in that report, they calculated that medication errors harm 1.5 million Americans each year. So certainly a large number. The next study, I'll kind of walk us through, is a little bit more complicated. They basically, a bunch of researchers in Arizona who basically wanted to estimate the total cost of medication problems. And in 1995, they estimated the total cost in the United States each year to be $76 billion. Now, that's a huge number, right? 76 billion. Well, what's really scary is that those same researchers updated that model, updated that study in 2001, and they had calculated that just in a 6-year period, the total cost went from 76 billion to 177 billion. Now, I've actually, in February, I had the chance to talk to them in Arizona and ask them, is there going to be a 2008 study coming out? And they are working on it. I'm kind of terrified to see, how big is the number going to be today? Is it going to be $1 trillion? But certainly, the trend is not going in the right direction, meaning that this problem is getting more serious. Another study that focused just on medication use in nursing homes or long-term care facilities, again estimating that the total cost in the United States is $7.6 billion. What's really scary is this one sentence in the study. They estimate that for every dollar spent on drugs in nursing facilities, $1.33 is spent fixing problems related to those drugs. So again, if you really kind of read into what they're saying we're spending more money fixing problems due to medications than the medications cost themselves. Now, they're not saying stop all medications. They're not saying that at all. But they are saying, we need to look carefully at basically the cost of drugs, and not just the cost, but the cost of the harm they cause. ER visits, hospitalizations, and other costs. Now, you might be saying, Neil, that's fine. These are American studies. Show me something in Canada. So to date, this is one study that I was involved in going back 2001, where we estimated kind of a combination of expert opinion with real cost data, and estimated that at that point in Canada, these costs just in seniors is $11 billion. So certainly a significant number in Canada. Another question often I get asked when I'm speaking to health professionals or to folks across Canada or internationally is how many medication errors happen in Canada? And unfortunately, this is a really hard question to answer because we do not have a really good national reporting system for medication errors. Now, each hospital, whether it's the QE2, whether it's Social Regional in Bridgewater, they would have their own internal systems, but we don't have really good reporting systems for errors. Now, there is one organization called the Institute for Safe Medication Practices. They rely on voluntary reports, and so it's a voluntary database, so it's a very conservative estimate. But in their numbers, almost 29,000 medication errors have been reported since the year 2000, and almost all those are just from hospital settings. They get very few voluntary reports from family physicians or from community pharmacists. These are almost all just from hospitals. And of those, you can see about 1,300 resulted in death or harm. So that's probably the best numbers we have in Canada, although certainly this is a vast underestimate of the problem because it's based on voluntary reporting. You might have seen this cartoon in the Chronicle Herald about 2 weeks ago. It was based on a recent survey of nurses across Canada. I'm sure if we have any nurses here, actually we do have at least one nurse here in the audience. Basically asking them, do you think you've been involved in a medication error? And 22% of nurses in Canada admitted that, right? And you have to think about that's quite a thing for them to admit. In this cartoon, yes, 22% of us admit to medication errors, but we're overworked, understaffed, and far too honest, right? And I think certainly most of us would agree with that if you've had interactions with nurses, that many nurses are overworked, understaffed, and obviously they're being honest with the statement. All right. So I've kind of, to date, showed you kind of what the evidence is as far as studies, what kind of researchers like myself or health professionals think. But what about average Canadians? Do they think this is a serious problem? Again, when we did that second quiz, how many of you think that adverse drug reactions is a really serious problem? Only a few of you put up your hand thinking it was the fourth leading cause of death. So what do Canadians think about this issue? Well, Canadians, if you think about us as a country, we're very passionate about healthcare, right? Almost obsessively so. If you think of that contest that CBC had in 2006, where basically the contest, who is the greatest Canadian ever, right? And they had the 10 finalists, people like Don Cherry, David Suzuki. Well, if you remember who won that, it was Tommy Douglas, right? Tommy Douglas. And for those of you that perhaps don't know who he is, he was originally a Baptist preacher turned politician who laid the foundations of our modern healthcare system in the province of Saskatchewan. So it's very bizarre if you think of that. As Canadians, basically we're saying our greatest Canadian ever is a person who created our healthcare system. Now, if they did this in Great Britain, probably be someone like Churchill. If it was France, probably Napoleon. But Canada, we chose this person who created healthcare. So I think this is something about us as Canadians, that healthcare is something we feel passionate about. Here's another cartoon as well. We often, comparing ourselves to other nations, especially the United States, often most Canadians feel that we have a better healthcare system. See this cartoon, this doctor dressed up as a Mountie. We're borrowing the best features of the Canadian healthcare system, right? So I don't know if we've seen that yet, other countries dressed up as Mounties, but at the same time, certainly there is, other countries do look to Canada as far as what we do related to healthcare. What I'd like to share with you in the next 2 or 3 slides are really from a fairly large international survey. It was a survey of 7 different countries, one of those being Canada. And basically it was just a company that did telephone calls to random citizens. There was about 3,000 Canadians that participated in this. So these are not health professionals, these are average Canadians. Basically asking them for their opinion about different aspects of the healthcare system. This slide's a little complicated, so I'll kind of walk us through it. First of all, the 7 countries that were part of the survey, Australia, Canada, Germany, the Netherlands, New Zealand, the United Kingdom, and the United States. Okay, so again, this is Canada. And basically, I'm just highlighting one small part of the survey. And basically, it asked citizens of these 7 countries, have you in the past 2 years personally experienced a medical or medication error? Have you experienced a lab or diagnostic error? And the last one basically combines that. So have you experienced either one of those? And you can see that according to this survey of, again, about 3,000 Canadians, 17% of Canadians said that, yes, in the last 2 years, I have personally experienced a medical error. Now, if you look at it, we're actually in the middle, right? Australia and the United States are the highest. So about 1 out of every 5 citizens, or 20% of Australians and Americans say they've experienced an error. But we're worse than, the lowest there is Germany. We're 12%. But we are in the middle. So that's, it tells something that basically 17% of Canadians feel they've experienced an error in the past 2 years. Now, I've done some math for you. If you're wondering how many Canadians does that translate to, this was just a survey of adults. And if you look at our last census data from 2006, there were about 25 million adult Canadians. And so that's 4.2 million Canadians. So basically almost the size of the city of Toronto, that every 2 years experiences a medical error. Certainly more people, again, than live in all of Atlantic Canada claim to experience a medical error. So, really it's a significant problem. Again, if we look at what Canadians themselves are telling us. They actually broke the data down a couple different ways. I just want to share with you these slides because I think it's interesting. The first one, basically, they look at patients that have one doctor and those that have more than one doctor. And I suspect that perhaps some of you in the audience tonight have more than one doctor. You might have a family physician, and perhaps you also see some specialists for other conditions, all right? So if you have one doctor in Canada, 13% of those folks said that they've experienced an error. But if you have 3 or more doctors that you're seeing, 30% of those claim to have at least one error. So again, certainly there might be issues there, but perhaps the doctors aren't communicating with each other. Maybe it has to do as well with the complexity of care, that these people have a lot of different conditions. This next slide looked at basically folks with 2 or more chronic conditions. So if you're someone here tonight that you have perhaps diabetes and high blood pressure, or a couple different chronic conditions, you're at greater risk as well. So again, overall, as we mentioned, 17% of Canadians said they've had a medical error, but 28% of those with at least 2 chronic conditions say they've had a medical error. So again, certainly not good news as well. So again, how seriously do we take this problem? Jerry Avorn is a well-known physician in the Boston area, and he says any symptom in an elderly patient should be considered a drug side effect until proven otherwise. And if you think about this, this is almost the complete opposite of the way that most healthcare works today. In that basically if you have some sort of symptom, you go see your doctor, they're trying to diagnose or trying to figure out, could it be this disease, could it be this? And perhaps at the end of it, they're, oh, by the way, what medications are you taking? So for most physicians, there are exceptions, but for most, it would be well down the continuum of questions. He's saying we need to completely flip that. The very first thing, if somebody has something going on with them, we need to think, could that be caused by medication? So certainly, at least in Dr. Avorn's mind, medication problems is quite serious. Perhaps there's going to be some spin-off to this. I'm not sure if we see this in a pharmacy near you, where we have anniversary cards, birthday, get well, and medication side effect cards. So perhaps there'll be some changes as a result of this. And of course, some folks would say that the safest place to be in Canada, this is kind of a cheap shot, would be Tim Hortons, right? So I don't know if we have any law enforcement folks in the audience tonight, but apologize if we do. All right. So again, we've really answered, I think, hopefully the first question of the evening, which is, how big is the problem? And hopefully I've convinced some compelling evidence, both from studies and from the opinions of Canadians themselves, that it is a significant problem. The next one is, what could be the cause of this problem? Okay, so given that we might have a problem with lack of safety with medications, what is the cause of the problem? Well, this was for those of you that have, I'm sure if we have any folks from Cape Breton tonight, or folks that have lived in Nova Scotia a long time, this was a case, really a sad event that happened at a Shoppers Drug Mart pharmacy in Cape Breton in 2000, where there was a mix-up with someone's diabetes medications. The person involved, the patient, ended up passing away. And her daughter, when she spoke to the Chronicle Herald about this, I think said something really insightful. And she said, we're all human and mistakes are made, although some mistakes are deadlier than others. And we kind of have different ways of saying this. Sometimes we say, well, we're only human, or mistakes happen. You've probably said that yourselves. Myself, I have a 4-year-old daughter and 2-year-old twins at home. So milk is always being spilt at the table, and you tell your children, well, mistakes happen. You don't have to cry over spilt milk or whatever you say. But at the same time, have you ever wondered, why is it? Why is it that we seem to make mistakes over and over again, often of the same kind? And so this is a question then that we asked both health professionals and we asked patients. This was a study we completed 3 years ago in Bridgewater, Nova Scotia, where we asked health professionals working in the hospital, and we asked patients that were recently discharged what they felt causes medication errors. We'd actually showed them some examples of errors that really recently happened in Bridgewater, and then asked them, what do you think causes those errors? And what was interesting from myself as a researcher was comparing what the health professionals told us to what the patients told us. I think we can gain insight from both. The health professionals told us that often multitasking is a source of error, meaning that if you think of maybe the average nurse in a hospital, right? She's trying to do so many different things. She doesn't just usually have one patient to look after. Often it could be 6 patients, 12 patients. They're trying to think of their medications. Other issues come up, answer family member questions. And for those of you that go to a community pharmacy as well, the pharmacist is doing different things, talking to physicians on the phone, filling prescriptions, perhaps calling insurance companies. So a lot of different stuff. And we know that when people try to do more than one thing at once, right, it certainly is a recipe for error. At the same time, again, we're not blaming physicians totally with this, but poor handwriting. We certainly, if you think about it, it's almost scary. It's almost bizarre that in today's high-tech world, right, for the most part, we still rely on handwritten small pieces of paper abbreviations written in a dead language, Latin, and basically somehow expect that that important healthcare information is going to be transmitted from the physician who writes it to the pharmacist who fills out prescription. If you think of the banking industry, almost any other industry, right? They don't rely on handwritten pieces of paper in a dead language to convey important pieces of information, and yet we still do that today. Transcription errors mean that in a hospital, often perhaps the physician might write an order, and maybe the unit clerk or nurse writes notes about that, so that could be an error. And also failure to follow what we call the 5 R's, meaning the right drug, the right dose, the right person, the right route, and the right time. Okay, so that's what the health professionals told us. The patients, what did they tell us? The first thing was, again, this concept of human error. In fact, that most patients seem to recognize, yeah, there is this thing called human error, that we are, mistakes happen, and that in healthcare, if we spent all our money in Canada trying to make the healthcare system as safe as we can, there still would be the odd error happening here and there. Secondly, patients unwilling or unable to provide pertinent information. If you think about just the typical emergency room setting, not every patient who enters into an emergency room is in a condition to give the health professionals all their pertinent healthcare information. So certainly that can occur. Overworked doctors and nurses. And I think certainly these patients who are lying in their hospital beds, they could hear what was going on in the hallway. They could sense the tension and the long hours that the nurses and doctors were working. So certainly that contributes to problems as well. Last was an interesting one. It said improper patient identification or failure of patient identification. And you might be kind of wondering, Neil, what do you mean by that? We actually had one patient in our group who mentioned that when she was in the hospital, patients, of course, get a wristband, right, when they're in the hospital, usually with a barcode, their name. Well, she said that her second day in the hospital, her wristband fell off, and no one ever checked for it again, right? If you think about that, it's kind of scary, right? So basically, if nurses and nurses' aides should be checking that to make sure it's the right patient that they're giving the drugs to, and yet her wristband fell off, and no one ever bothered to check that again. So certainly a lot of different problems or causes of medication errors. What you can actually is kind of combine these into 2 general categories. And certainly Don Berwick, who's a well-known physician at Harvard, has done a lot of work in this area. He kind of combines errors into 2 general categories. The first being design errors or failures related to a process, task, or equipment. So a very quick example would be a patient in their hospital bed. They have an IV, and there's a hole in the IV tube, so the medication leaks out. So that would be an example of basically a design error. Probably the more challenging ones, though, it's fairly easy to catch those things like holes in tubes, are what we call organizational and environmental failures. The first being psychological precursors. That's kind of a fancy word, basically meaning stress. Now, I'll do another kind of quick questionnaire here tonight. How many folks have ever watched a hospital drama on TV, like House, like ER, maybe years ago, St. Elmo's Fire? How many people have ever watched a medical drama on TV? Okay. How many people have ever watched on TV a show about nursing homes? Okay, so a few of you actually have, okay. Which is kind of ironic, because usually I do this and no one puts up their hand that they've watched a show about nursing homes. Most of us, I think, most of us in life, we're kind of drawn to those kind of intense shows like ER, House, right? Where it's crazy. We don't know what's going to happen next, what kind of patient's going to roll into the emergency room next. There's going to be blood flying everywhere. It's going to be chaos. It's crazy. It makes for interesting TV viewing. I don't know if it makes for interesting actual care. If you compare that to the average nursing home, right? That's probably why there's not top-rated shows about nursing homes, because again, it's the stress level is different. Now, it's not to say that errors don't happen at nursing homes, because they do, and different kinds of errors often happen. But as far as the stress, we know that when people are under stress, right, that again can cause errors to happen. And it's probably no wonder then that if you saw today's paper, the new study about 1 in 9 folks who came to an emergency room, right, that they came there, it was due to a medication problem, that folks are arriving in the emergency room with problems, and then actually in the emergency room as well, more problems can arise as well. The second thing related to that is team functioning and communication. And certainly healthcare professionals are dedicated to people's health, and they're for the most part great people. But healthcare professionals, whether it's myself, Dr. Gray, or for example Marilyn in the back, there was a nurse. we're all people as well, and that we function in teams. Sometimes people fight in teams, they don't get along. And just if you think about, let's say in a community pharmacy, let's say a pharmacist had an argument with a pharmacy technician, they have to work a 12-hour shift together in that pharmacy. How do you think that might impact the care of those patients if the pharmacist is not talking to the technician? So certainly team communication and functioning can be an issue. Lastly is education and training. And in some ways, we're stellar in Canada in that our healthcare professionals receive phenomenal training. But at the same time, if you ask those healthcare professionals, how much education did you receive in your training about how to reduce and prevent errors? Most would say it was very little, if any. Actually, Dr. Burrick, his daughters are just finished medical school at Yale University, and you would think that Yale would have, a great program on safety. He said that his daughter only had 1 hour in the entire 4 years of medical school on Yale on how to prevent errors. So again, it's probably no wonder that errors are happening if we're not educating our healthcare professionals on how to prevent errors. And what Dr. Burrick says is that systems produce precisely the outcomes they are designed for. So if it's a system that's not designed well, where errors happen, where mistakes happen, again, it's really no wonder that we're seeing these sorts of problems. If you look more specifically at medication use, it's really been argued that there's really 8 core things that need to be in place for every patient who receives a prescription. And certainly, as Dr. Byrne mentioned, I have a book that focuses on this. I'm not trying to sell this tonight. This is really directed towards healthcare professionals, so there's no financial incentive for me to promote it. I'm not. Again, it's really designed for healthcare professionals. But in it, we walk through these 8 elements in quite a bit of detail. So I'd like to kind of share that with you tonight. You can really use this all as your personal checklist as well. So you can really, if you take medications as an individual here tonight, you can kind of go through this list in your mind and see, are all 8 things in place for me as a patient. The first thing is timely problem recognition and diagnosis. And certainly we know there's a problem with underdiagnosis. Lots of conditions such as high blood pressure and diabetes are underdiagnosed in the country. We also know that there's also the timely aspect can be critical for certain conditions. For example, folks that have a heart attack, right? We know there's actually a very short window where that needs to be properly diagnosed and the right drugs given. And even if it's a couple hours too late, then those drugs will have no benefit. Now this is a good example of timing. I just wanted to share this really short story. This is a woman, her name is Dorothy Fletcher. It says, when Dorothy Fletcher collapsed from a heart attack on a flight to Orlando, she might have expected the usual retired surgeon, liver specialist, or new age healer to come to her aid. Instead, when the cabin crew put out a call for a doctor to help her, 15 cardiologists, all going to a cardiology conference, immediately pressed their call bells. In the end, Fletcher, who was 67, who was on her way to her daughter's wedding, made do with 4. One gave her oxygen, another set up a drip to thin her blood, while 2 others monitored her blood pressure. So that's perfect timing, right? If you're going to have a heart attack, have it on a plane that's filled with cardiologists going to a conference. The next element is safe, accessible, and cost-effective medications. And obviously, the safety part is key, right? We want medications on the market approved by Health Canada. We know that are safe enough for Canadians, effective as well, that actually do what they're supposed to do, and at the same time be cost effective. And certainly we know for a significant number of Canadians, the rising cost of prescriptions is a real challenge. The average cost of just one prescription now is $45, but there's many, many more that are more expensive than that. And even if, for those of you that might have insurance plans, there's sizable co-payments. There might be drugs that aren't included in your plans, and so this can be a real issue as well. Number 3 is appropriate prescribing. And for this, certainly, I think in some ways it's easy for me as a pharmacist to stand up here tonight and say, yes, doctors need to do a better job of prescribing. If you think of all the different drugs out there, doctors actually do a phenomenal job as far as trying to go through all those different drugs, select what's the best one for the patient. The part that probably could use the most improvement, though, is that often the doctor has in his or her mind what's the objective of the medication, but often that objective is not communicated to the patient and certainly not to the pharmacist filling that prescription. So certainly, as far as prescribing medications, again, what's the objective of that medication? And certainly if you're a patient tonight taking medication for each one of your medications, as we'll discuss in a few moments, you should know what is the objective, what is the purpose why am I taking that medication? Number 4, distribution and tailored patient advice. We need to get the right drug to the right patient. If you think back about 3 months ago, if you heard the story about Dennis Quaid, the Hollywood actor, who with his newborn twins in the ICU were given a dose of heparin that was 1,000 times too high, and the twins almost died due to bleeding. In that case, they just received the wrong dose of the drug. So certainly those sorts of errors do happen. Number 5, patient participation, and something what we call intelligent adherence, meaning that we really, folks, for any of you that are taking medications, it's important that you're an active partner with your healthcare professionals, and as well certainly follow the prescriptions, the directions, but certainly if you're developing side effects or stuff, it doesn't mean that you keep taking it and don't question it. You probably should contact your doctor or pharmacist and ask about it. So again, what we call an intelligent adherence. Yes, it's important to adhere or to take your medications as directed, but at the same time as well, still use intelligence, and it's okay to ask health professionals questions if you're not sure about things. Number 6 is monitoring, meaning that for many patients, they get their prescriptions, they go to the doctor writes prescriptions, they take it to the pharmacy, get the prescription filled, and that's the end of it. And that really shouldn't be the end of the process. Really, ideally, the pharmacy should be calling them to make sure that they're doing okay. Ideally, the physician should probably schedule, for a lot of medications, a follow-up visit to make sure, again, that's working well. So again, that monitoring piece needs to be in place. Number 7, documentation and communication, and I'll have some vivid examples of that in a minute, so I'll save that. And lastly, what we call system improvement, measurement, and evaluation. Again, looking at the big picture, for example, for Nova Scotians, are we prescribing the right medications or not? I just wanted to pick kind of 2 of these that I think are key. The first being monitoring, and just share with you a local study that I was involved in to kind of show you, on a practical level, why lack of monitoring is an issue. This was a study where we basically looked at, for a 2-year period, every senior who lived in the western part of Halifax, basically this side of the harbor, and looked at the medications they were taking and looked at whether that medication could have caused an emergency room visit, a hospitalization, a nursing home visit, or even death. And quite scary, we actually found that about 1 in 7 seniors experienced what we call a preventable drug-related morbidity. So again, over this 2-year period, 1 of every 7 seniors living in this part of Halifax experienced one of these problems. To give you an example, if you're kind of saying, Neil, give me a practical example, we found 519 seniors who had an emergency department visit or hospitalization, who were basically on the right drug for treating their thyroid, but they never had the lab work done to adjust the dosage properly, and as a result, they showed up in the emergency department basically with what we call hyperthyroidism. So again, totally preventable if the dosage had been adjusted properly, but they were prescribed the right medication, but they never had the lab test done as a result. Another example, and this is from also local at the QE2. At the QE2, currently and every hospital is a little bit different, but at the QE2, there's really kind of 3 different record systems that health professionals use related to medications. And I realize that the font here is kind of small, so I apologize. So at the top, basically, is a physician's order from the chart. So again, the physician, in his or her own handwriting, is writing in the chart basically what the medication is, okay? That order then gets a copy that gets pulled, and the pharmacy department has a computer they enter that order into, okay? Then the nurse on the floor who's going to give that medication to the patient, she or he has their own kind of handwritten record as well to remind them, oh yes, this patient needs this medication. So think with this. So one hospital, the QE2, has 3 different record systems for medications. And in this problem, this study basically looked at, are these 3 systems, the doctor's order, the computerized pharmacy system, and the nurse's records, are they the same or not? So is the same medication written on them? And what we found is that about 1 out of every 8 medication orders, there was some sort of mix-up. And this is kind of a bizarre example. The one, this is, again, I apologize, it's small font. It's for Effexor, and it was written by the doctor, Effexor 75 milligrams, PO-BID, means orally twice a day. And the bottom one here, the pharmacy system, was actually changed for some reason to the generic version extended release, which is quite different. So basically meaning that the dosage and everything would be off. And then back in the nursing record, the middle one was changed back to the original. So it's kind of a bizarre, in this case, it was actually no error because it was changed back because the two errors canceled out the problem. But certainly, this is quite scary. We expect that patients go to the hospital to get better, and yet we certainly see a large number of these problems. All right, this might be the slide you've been perhaps waiting for. Neil's finally done talking about the problems. We'll kind of move off the bad stuff, and hopefully, again, that wasn't too much, but focus maybe on more of the positive solutions. So what can be done to fix the problem? And perhaps you're asking yourself, okay, if we know what causes errors, right, we just talked about the causes, why do these things still happen? At least why do they happen so much? Certainly there are a lot of effective strategies for reducing medication errors, but like anything, the devil's in the details, and often trying to implement these among healthcare professionals who are already overstretched, overworked, it can be an issue. The first is reducing handoffs. And what I mean by that is basically a handoff is any time the care goes from one healthcare professional to another. Now let's use an example of going on a flight. Let's say that this is your lucky night. We're going to have a free drawing. Joe doesn't know this yet, for a flight to Orlando. Okay? So let's say that you win that drawing tonight and that tomorrow you can go to Orlando. Let's say that's a direct flight. Now the chances of you making it with your luggage is pretty good, right? But let's say that instead of a direct flight to Orlando, you go to Toronto, then Boston, then New York, then Washington, then Atlanta, then Orlando. Now at the end of that flight, how do you feel? Not so great, right? And what are the chances you think that your luggage made it and that you made it there on time? Not so great. Well, in healthcare, we have a lot of what we call handoffs. In fact, it's not uncommon for hospitals to have as many as 17 different handoffs from the time that the doctor writes the order in the chart to the patient actually receives it from the nurse. 17. So it's no wonder then, and again, every handoff is an opportunity for error. Next one, increasing feedback. And for this, it could be something as simple as physicians finding out, how is my prescribing compared to those of my peers. Often physicians don't receive a lot of feedback. They may have spent 30 years practicing medicine, but how often do they actually get told, yeah, you're doing something good here. You're prescribing really well. How often do they get told that? Increasing information availability. An example there would be, some of you might think this happens, but it usually doesn't, that the community pharmacist, it's very rare that they actually know the reason why the patient is taking that medication. Most doctors do not write, for diabetes, for high blood pressure. Now, the pharmacist often they might know the patient, perhaps they talk to them, they ask questions, but still, the pharmacist shouldn't be having to play a detective, trying to figure out, what is this medication for? Obviously, if they don't even know what it's for, often it's hard for them to counsel properly and provide good information to the patient. Decrease lookalikes or sound-alikes. It's kind of scary that in today's kind of modern world with technology, we still have a lot of drugs that, again, if they're written out by handwriting, they look alike or sound alike. An example would be Losec, which is a drug for ulcers, and Lasix, a drug for blood pressure. They look a lot alike, right? And often with poor handwriting, they look a lot alike on prescription pads as well. Now, what's scary here, the company that actually makes Losec, AstraZeneca, in the United States, they had so many errors, they actually changed the name in the United States to Prilosec. But in Canada, they kept the same name, so I guess they figured that Canadians were gullible and we don't have those kind of problems. But it's kind of scary, right? Again, if you think about, and this is just one example, there's a lot of other examples still today. Move to what we call e-prescribing or electronic prescribing. Certainly there are some areas in the country where this is happening, and ideally as Canadians we'd like to see this, where basically the doctor types a prescription in their computer, gets sent via email right to the pharmacy. And there are some projects. There's one in the western part of Montreal, which actually the physician also finds out when the patient went to the pharmacy to pick up their prescription as well. Workload and work hours of health professionals. Again, we've already kind of touched on this, but it's not uncommon for many nurses to work night shifts or shifts back-to-back or 12-hour shifts. And you think of that, the end of that 12-hour night shift, right? What do you think the chances of an error happening are compared to maybe the start of that shift? So certainly a real issue. Interdisciplinary care, certainly we know that when health professionals work together as a team, that these communications improve, these sorts of problems are reduced, and yet ideally that sort of situation is very uncommon in healthcare. It's very rare, right, to actually have to go see your family physician, see the nurse at the same time, see the pharmacist right in the same physical location. Often you kind of have to hop around and go to different spots. The last one is what we call better reporting and fear of reporting. And really what we mean by that is that certainly for a long time, health professionals were was kind of this code that, yeah, we don't talk about errors. Or worse yet, they actually, a doctor or nurse admitted they made an error and they got fired, right? That would really fix the problem, right? And now, luckily in healthcare, we've kind of moved away from that, though certainly in some cases this still happens. And you just think about that yourself in life. If you make a mistake, the last thing you want to do is broadcast that to everyone, right? You feel horrible, maybe you got this sinking feeling in your gut no matter what kind of mistake it was. And certainly in healthcare, those sorts of issues are compounded and we're dealing with real people's health. So certainly, that still is an issue. How do we convince health professionals to admit to mistakes, to report them? And the reason we're doing that, again, we're not trying to single out individual practitioners saying you made 5 errors last month, you're a bad nurse or you're a bad pharmacist. What we'd like to do is learn from those. And certainly we know that an error made in a pharmacy in Victoria, well, perhaps the pharmacist reached for the wrong bottle. Well, that's probably useful to pharmacists here in Nova Scotia as well. So that's very important as well, as to improve reporting. At the same time, you might think, well, that's easy. We just perhaps pay health professionals to report, or we don't fire them, or we don't blame them. But again, it's often really hard to cause change. One person who's certainly not a household name today is someone called Ignaz Semmelweis. He lived about 150 years ago in what was then Hungary, the Hungary kind of area in Europe. He had this radical idea that physicians should wash their hands before they see patients, right? Now, you think about that today, obviously that's accepted, good hand hygiene, that we should do that. And yet, in his lifetime, he actually was ridiculed, he lost his job, and basically his peers just ignored him, saying, that's a crazy idea, that will never fly. Now, if you think about that, you can say, okay, Neil, that was 150 years ago, that would never happen today. A more modern example, these are two individuals. Barry Marshall's the person sitting down, Robin Warren's standing up. They're two healthcare professionals in Australia who in the early 80s had the idea that most ulcers are caused by a bacteria that lives in your stomach. And again, this is the early 80s. Now, again, these folks were ridiculed among their peers. They tried to present this at scientific meetings and people laughed at them. They left the room. And what it came down to is that the person sitting down, Dr. Marshall, actually decided to swallow a bacteria, a culture of this in a test tube. He got a stomach ulcer, and that was kind of the proof that people were looking for. The good news is that, again, their ideas were eventually accepted, and actually they won the Nobel Prize for Medicine in 2005. But yet, still, they went through a period of about 10 to 15 years where nobody believed it. How can a bacteria live in your stomach? That's acidic. How could anything ever live in there? And yet, again, they faced a lot of hostility. So it is hard to cause change in healthcare, and especially reporting errors, again, is a very sensitive topic. I kind of wanted to share with you a couple of nice success stories as far as local institutions and facilities which have done things to improve care. This first one's from the Moncton Hospital, and this is actually a very simple idea. What they did at this hospital was that basically moments before the patient was discharged, they had the pharmacist review the patient's medications, come in the room with them, if they had their family members there, counsel them. They actually had a printout, I'll show you in the next slide, that had a color picture of all the pills. And then they also sent that printout to the patient's community pharmacy and to their family physician. Okay, really simple idea. So basically talking with the patient, educating about their medications, and making sure that the next healthcare professionals, their hometown family physician, their hometown community pharmacist, had an accurate list of medications. And you can see that as part of this project, when the pharmacist went into the patient's room, she found an average of almost 3.5 drug-related problems. So again, this is just moments before the patient's about to leave, and she found an average of 3.5 problems. And again, these were pretty significant. This is a copy of the printout. So again, this is not really complicated, right? This is pretty easy stuff. The name, both brand and generic of the medication, a picture of it, the dosage, and also when they should take it. And again, she would print this off, give it to the patient, and then the patient would have that in their files. Now, shouldn't every hospital be doing this? Right, and does this cost a lot? Not really. A very simple idea, and the good news is that this was a study actually we conducted way back in 2001, and if you go to the Moncton Hospital today, they've actually expanded it so every single patient who leaves the Moncton Hospital receives this. So again, not a really complex idea, but has a real potential to improve care. The nice part is that, and we call that seamless care or medication reconciliation. Again, a very simple idea, really the Moncton study again from 2001, it has caught on, so even though not every hospital is doing it, more people are interested in it. In fact, most recently, the World Health Organization decided this was a good idea. This was a meeting that I attended in Washington last November. That's our Federal Minister of Health, Tony Clement, and he's signing basically Canada's participation. Canada's one of 7 countries participating in patient safety strategy. And that thing I just showed you about the printout with the medications, that's going to be one of those 5, one of the 5 strategies in those 7 countries. So that's good news. The other kind of good news story. This is another example from the province of New Brunswick. It's a study that was quite unique. Involved a Medavie Blue Cross, 7 different employers in New Brunswick. For example, Moosehead Breweries was one of those. GlaxoSmithKline was a drug company in Dalhousie. And basically, in the study, it was directed towards folks with asthma. And basically, the idea was that instead of people who have asthma, not feeling well, trying to schedule an appointment with their physician, taking time off from work, maybe they have a sick child, they have to take them out of school early, why not bring the health care to the workplace? And so as part of this, they actually had a trained nurse who was an asthma educator at the workplace who would do education, who would see patients, and the intent was not to replace care, but basically decide, okay, yes, you need to go see your doctor, or yes, you need to get to the emergency room right away, or no, it's actually something that we can work on together. I want to see you perhaps tomorrow or the next day. So not, again, a real complex thing, but something simple, really, again, trying to bring care to people in the workplace. We had 99 folks that were part of this, and on her first visit, her very first time she saw these patients, she found almost an average of 2 problems per patient in this. The number one problem she actually found were people who were not on the right medications for asthma. They were on, most people with asthma are on a medication to help them breathe easier and also one to reduce inflammation in their lungs. And a lot of people were not on the drug to reduce inflammation in their lungs. How did it work? Well, we actually, she measured basically how well people used their puffers, inhalers. See a huge improvement. After 9 months, the folks actually felt more productive at work. Their quality of life improved, and they were taking fewer sick days at work. Mike Lee, who's Vice President of Human Resources at Moosehead Brewery, said employers need to take a value approach to drugs versus a cost approach. And what he means by that is that in this study, asthma drug costs actually went up because, again, she found people that weren't on the right drugs. So this ended up costing the employers more money. But did he see the value in it? For sure, because they weren't taking sick time. Their disease was more under control. They felt healthier, and we're doing better as a result. All right. Well, we've made it to the last expeditions. You guys have been a very patient audience. So our last one is, how can you personally reduce your risk for experiencing a medication error? Again, a lot of this really is quite common sense stuff, but unfortunately, not everybody follows this advice or perhaps doesn't know about it. The first thing is really just knowing your medications. And here's an example of that. Quick, drink this. It'll settle your stomach. So some medications are stranger than others. If you think about why does that work with looking like that. So for example, again, we've talked about this already, the purpose of the medication. So why is it that you're taking each one? And for that, even to be as specific as possible. So if you're taking a medication for blood pressure, not just knowing, yeah, this is for blood pressure, but exactly, is this something I'm going to be taking for life? What level or what readings is my doctor trying to get me at? Trying to get as specific as possible. Obviously, potential side effects, and there's a balance here. We don't want everybody to be totally paranoid and worried because we know that for a lot of drugs, a lot of side effects can happen. But fortunately, often they're quite rare or not serious. But for any given drug, there's usually 3 or 4 major side effects to watch for. So certainly, as a patient, you should be educated about that. How do I know it's working? Now, for some drugs, yes, it's a no-brainer. If you're taking a drug for an infection, you kind of wait, but there's other things. For example, for cholesterol, actually you're not going to feel any different taking a medication. You actually might feel worse taking the medication, how do you know if it's working? Even just knowing every little detail about your medication, the color, the shape of the tablets, are there markings? And again, so that if for some reason you come back from getting a refill and it looks different, you'll be informed and you can call the pharmacy and find out, last time my pills were round and red, this time they're blue and square, what's going on here. How to take it, what to do if I miss a dose, again, some basic information. And certainly it's valuable, if you don't have it already, is to have somewhere a complete and up-to-date medication list. Because again, we don't want to think about worst-case scenarios, but let's say, for example, something serious happened to you, you were perhaps in a coma or maybe in a car accident, not able to speak, you'd have this list. And really, this should not just include your prescription medications, but any over-the-counter drugs you're taking or even herbal products as well. All right, secondly, get the most out of your interactions with physicians. And for some of us, we kind of fear going to the doctor, right? We kind of fear these kind of things. You might feel a little prick. We're worried about, what's the doctor going to do next. But at the same time, even before you see your doctor, so if you have an appointment scheduled, thinking about what do you want to get out of that meeting with the doctor. We know that typically you're only going to get maybe 5 minutes, right? We know that for most of us in Canada, our visits with our physicians are very short. But it doesn't mean that you can't kind of go into that visit already thinking in your mind, okay, yeah, I need to ask these 2 questions, write them down, and just remind yourself, I'm not going to leave until I have these questions answered. Interactions, again, during the office visit, again, and for some Canadians, they kind of feel guilty. They perhaps are in the waiting room and they feel, well, these people are sicker than I am. I don't want to take up valuable time or whatever. But at the same time, you probably all have issues that you feel are important to you, and don't be afraid to bring those up. And also follow up after the office visit. So, for example, if the doctor prescribes you a new medication, before you leave that room, to ask them, okay, do we need to schedule a follow-up visit for this? Is somebody going to contact me? Are there any lab tests that need to be done with this drug? Asking questions like that. All right, the last one is getting the most of your interactions with your pharmacist. And for a lot of people, they're really not sure exactly perhaps what a pharmacist does behind that counter. And so what I thought I'd share with you are just some drawings from school kids in the Halifax area. We actually asked them, what does a pharmacist do? And when you ask kids questions like that, you have to be prepared for anything, right? So this first one, this was Steve, and an interesting pharmacy. First of all, Steve's crying. I don't know if you can see this in the back. He has tears streaming down. So I don't know if I've seen that in pharmacies, children sitting on stools crying, but that's not good. The pharmacist looks happy, though, and they're making a lot of money. You can see the cash register is wide open. $1 bills, 10s, 20s, and 100s even in there as well. And needles lying around, if you see that on the top in a pharmacy. And interesting hours, open at 4 and closed at 10. So I don't know if I've seen that before. This next one, as we talked about, it's important to receive good counseling from your pharmacist. But this one here, so it's concise, but probably not really valuable information. The pharmacist looks like they're having a bad hair day as well in that picture. Next one, Fiona drove one. I don't know if she's saying you need medicine or medicine you need, but again, needles. So all these kids are fascinated with needles, I guess, in this pharmacy and lots of different drugs. But in this case, she looks happy, so that's an improvement. This one, this pharmacist, Judy, says, say hello to our pharmacist, Judy, and she's also the employee of the month. And it's a pretty good portrait of her as well, I'd have to say, so that's good. This next one, I'm not advocating Lawtons here, so I'm being impartial, but it is Lawtons. And they say, pharmacist saying, here's the medicine for your cold, sweetie. And she says, thank you. And she even has a little happy face in her balloon, so that's a good one. And one last one, I know this one's really hard to read. I'll read it to you. It says, pharmacist is a person who I see as being a good person. I get medicine from him or her that helps me get better. Okay, so that's, probably is. If pharmacists saw that, they'd go, in the audience, right? They'd be pretty happy with that. So those are, we kind of reviewed, that's what children think pharmacists do, but actually what do they do? Well, certainly behind the counter, they're using software programs to check for interactions. Obviously, they're make sure that if you're have an insurance company, making sure that payment goes through as well. But still, before you leave the pharmacy, you should make sure that you receive both verbal and written information from the pharmacist. Okay, that they've told you, again, purpose of the medication, what's it for, the major side effects look for, and as well, for those of us, perhaps if you're in a pharmacy, sometimes it's a busy place, there's people around, sometimes it's hard to take everything in, so you also should receive written information as well with that. Many pharmacies, people don't realize, do this, offer something free called callbacks, where if you ask them, can you check on me in 3 or 5 days, the pharmacy will schedule a time when they'll actually call you at home and ask you, because you're kind of in your favorite chair at home, you can ask them more questions than you could at the busy pharmacy. They'll make sure, are you having any side effects yet? Is it working okay? So if you ask for that, again, it's a free service that many pharmacies offer, but many people don't know to ask for it. So you just say, can you do a callback? Can you call me in 3 to 5 days? And most pharmacies would be glad to do that. Something a little bit more in depth, and not every patient would require this, but something called a medication review. In the province of Ontario, pharmacists actually get paid $50 to do this now, and there's a pilot program in Truro where patients are being involved here in Nova Scotia. But even if pharmacists aren't getting paid, most would be willing to do this for free. We're basically saying, can we set aside a time, if they have a private counseling room, that'd be best, where I can bring in all my medications, you can look at them all, and we can decide, are there any I don't need to be on, or some, that maybe we can create one of those sheets that I showed you before, where you can print off all the things. So let's call it a medication review. All right, so we reached about the end tonight, so I just want to kind of summarize again. Hopefully I succeeded in covering these 4 areas. So again, we talked about how bad is the problem of medication usage and errors. We talked about the causes of the problems, what can be done to fix the problems. And lastly, I kind of reviewed 3 different areas: knowing your medications, your interactions with your physician, and interactions with pharmacists, practical things that hopefully will help you out as well. In life, often there's shortcuts. Sometimes shortcuts are not helpful, like this one in Florida's fitness center, not a helpful shortcut. But hopefully tonight I've shared with you maybe some shortcuts or some tips for medication use that you would find helpful. The last thing that I'd like to share with you tonight is a short story. And certainly one thing we've probably picked up on tonight's talk is really encouraging you to be an active participant in your health. I'm totally convinced that if you know your medications inside out, that you have a lower chance of experiencing an error. If you're not afraid to speak up and ask questions to your physician or your pharmacist, again, you're going to get more value out of that time. And again, certainly we know that Canadians who take an active role in their health, as a general rule, do better than those who kind of just passively sit by. This is a short story that echoes that. It's called The Window. G.W. Target, in his essay The Window, tells the story of 2 men confined to hospital beds in the same room. Both men were seriously ill, and though they were not allowed much diversion, no TV, no radio, no books, their friendship developed over months of conversation. They discussed every possible subject in which they both had an interest or experience, from family to jobs to vacations, as well as much of their own personal histories. Neither man left his bed, but one was fortunate enough to be next to the window. As part of his treatment, he could sit up in the bed for just an hour a day. At this time, he would describe the world outside to his roommate. In very descriptive terms, he would bring the outside world in, describing to him the beautiful park he could see with its lake and the many interesting people he saw spending their time there. His friend began to live for these descriptions. After a particularly fascinating report, the one man began to think it was not fair that his friend got to see everything while he could see nothing. He was ashamed of his thoughts, but he had quite a bit of time to think, and he couldn't get this thought out of his head. Eventually, his thoughts began to take their effect on his health, and he became even more ill with a disposition to match. One evening, his friend, who sometimes had difficulty with congestion and breathing, awoke with a fit of coughing and choking and was unable to press the button for the nurse to come to his aid. The frustrated, sour man lay there looking at the ceiling, listening to the struggle for life next to him, and doing nothing. The next morning, the day nurse came in to find the man by the window dead. After a proper interval, the man, who was so eager to see out the window, asked if he could be moved, and it was quickly done. As soon as the room was empty, the man struggled up on his elbow to look out the window and to fill his spirit with the sights of the outside world. It was then that he discovered the window faced a blank wall. And, pretty powerful story if you think about it. 2 people, the exact same situation, not really pleasant, right? Confined to a hospital bed, both unhealthy, and yet one person, right, what he decided to do is make it a better experience for both. And I think, that again is a pretty powerful story showing, why it's important to take an active role in health, not just to be kind of a passive person whether you're in a hospital bed or at home, but certainly to understand your medications and really kind of take control of your health. So with that, that's really all the formal presentation. Maybe I'll turn over to Dr. Byrne.
Thanks very much, Neil. That was an excellent presentation. Now I'm going to call upon Dr. Jean Gray. Dr. Gray is well known nationally and internationally, and her stature is given best testimony by her designation as Professor Emeritus. She's Professor Emeritus of Medical Education, Medicine, and Pharmacy. Dr. Gray.
I too want to reiterate that that was really a superb overview, and if you've been taking notes, you will, I think, have some very practical recommendations to take home with you today. I think there's a couple of things I'd either like to augment or emphasize in what Neil has said. And I think there is a very real difference between medication use in hospitals versus medication use in the pharmacy. I warned him I was going to say this, so he knew this was coming. Problems in hospitals do frequently arise because of systematic problems. The handoffs that he discussed, for example, is a real issue in hospitals with the multiplicity of handoffs. And one of the dilemmas that both the medical and the nursing profession are finding these days are reconciling long shifts, which reduce the numbers of handoffs, but also increase the amount of personal fatigue, with the idea of having shorter shifts, but then having more frequent handoffs. And there's no real resolution right now as to which is the better technique for reducing errors, and I think we will be getting that information, but we don't have it at the present moment. So hospitals are probably about 100 years behind the aviation industry, which have a very detailed format for evaluating problems that arise and deal with them very effectively. That's why we have to listen to all that spiel at the beginning of every flight, and where we have to always fly with our seat belts done up and our seat back up and our chair table up and so on. That's all part of the safety procedures. But we haven't reached the point in hospitals where you have to listen to that kind of a spiel. But I think it will come. I think inevitably it will come, so that we can reduce the likelihood of medication error in the hospital environment. In the community, it's a little bit different. You are a far more active participant in your health care in the community. You first of all went to the physician of your own volition. Secondly, by and large, with few exceptions, you're capable of asking questions, and more importantly, you're capable of getting answers. And so I think in that particular environment, you really must be a very active participant with your healthcare professional. And in most instances, the chronic use of medication is because of chronic disease. So it is critically important that you know what you're taking, that you don't get a substitution when you go to the pharmacy, and that you understand how to take it and when to take it. My only minor beef is that when you get the handouts at the local pharmacy, they're sometimes so detailed that they're overwhelming for the patient. And I see so many heads nodding. I know that you all know what I'm talking about. They're filled with side effects with no sense of which are most important and which are least important. And the one thing that always used to frustrate both patients and me was when the 65-year-old man who just had a heart attack got his drug prescription filled and was given a handout that told him that he shouldn't get pregnant. The problem, therefore, is that these are not tailored to the individual, and they need to be. And that's one of the issues why I would support what Neil was suggesting, which is that you ask for a counseling session with the pharmacist so you know what you need to know, not what this huge long printout tells you. Okay? It's just like when I just bought a new car, so I'm very familiar with it. So I have my owner's manual, which is this thick, and now they're giving you a nice glossy little pamphlet that tells you what you really need to know. I've only read the glossy little pamphlet, but that's what's really important. The other thing that I really want to emphasize that Neil didn't address, and that is that there are a lot more medications that can cause errors or problems for you than those that a physician prescribes. It's not at all uncommon if you ask someone to come in, particularly as I dealt with relatively significantly ill and chronically ill patients, to have them come in with a Sobe shopping bag with anywhere from 20 to 25 medications in the bag. About 10 or 15 of them may have come from physicians, particularly as in many instances, as Neil pointed out to you, many of these patients were seeing more than one physician, so they had multiple prescriptions. But then there are the prescriptions that grandma suggested, or the next door neighbor suggested, or the husband loaned them, or they bought at the health food store, and those are almost as common as the ones that a physician prescribes. And these are not trivial. For example, St. John's wort, which is a very well-known health food or nutraceutical medication that does not require a physician's prescription, can have major drug interactions with a large number of prescribed medications. So these are not trivial, and they need to be part of what you share with your physician when you go in with your medications. Similarly, over-the-counter drugs are not trivial either. There are a large number now of over-the-counter drugs that are really quite potent in their own right. Some of the drugs that we use, for example, for treating peptic ulcers or ulcers, as was pointed out by Neil, used to be prescription only, but they're now available over the counter. There are a host of other medications now that are available over the counter. That's the way it should be. The patient should have the availability of medications that they can use themselves. These have been carefully screened. They are safe in the right circumstances. But it's important to recognize the right circumstances. And similarly, when you take your medications in to have them reviewed, that you include the aspirins, the acetaminophen, the Motrins, the Aleve, the ibuprofens, the Zantacs, or so on, that you have in your medicine cabinet, but you bought yourself. You didn't actually get as a result of a prescription from a physician. So with those caveats, I've supplemented a little bit of what Neil said. He really gave you a very clear and comprehensive overview. Our responsibility now is to do what the aviation profession did 25 years ago, get our act in order and improve the situation, even if you do have to listen to putting your seat backs up and your chair tables up. Thank you.
Thanks very much, Dr. Gray. So what we'll do is just open up for questions if people have some questions or comments. The floor is open.
I have a question, just out of curiosity. It doesn't apply to me myself, but a friend. And she has been taking medication for many, many years for her nerves. Is it possible that after a while this becomes immune to her system and no longer is effective? Because I see a change in her personality, the way she's behaving.
Sure. So yes, just for those who may not have heard, it's basically a colleague or friend that has been taking medications for nerves for years. Just wondering if over time, if it doesn't become as effective. And certainly there are drug classes where that may happen, where what we call tolerance or it's not as effective. Probably, it's hard for me to say without knowing the situation. I'd hesitate. But at the same time, certainly, a general piece of advice would be anyone who's been taking a medication for a long, long time, it doesn't hurt to kind of revisit that with their physician and say, should I still be taking this? Is the dosage still right? Especially if they don't feel it's working for them anymore.
Well, she doesn't see it, but I just see it.
You see, yeah. So that's even a little bit trickier, right? If she doesn't. But certainly, as a general advice to her, it could be, perhaps, just talk to your doctor, see if you still need to be on that, or if there's, because you've been on it for so many years, if there's anything.
15 years.
Yeah. It's certainly not uncommon for people to be on certain medications for 15 years or more, especially as people are living longer and there's a lot of chronic conditions. But at the same time, well, for example, there's quite a few studies done in nursing home situations where they find a lot of people when they're admitted to a nursing home, they're on a lot of medications that they really don't need to be on. So again, I'm not suggesting that for your friend, but at a minimum, the piece of advice I would have to her is, it doesn't hurt to next time she has her doctor's visit, just to, good question.
Neil, what role does the kind of professional tension, I guess, between the kind of different disciplines in the healthcare professions, what role does that play in, you know, you got the doctors, the pharmacists, the nurses, you got some professional tension between those groups. What role does that have?
Yeah, no, excellent. That's a really insightful question. Certainly there's, you know, again, like in a perfect world, every health professional group and every health professional individual would get along and be a nice family or a nice team. But certainly we know that's not always the case. I would have to say that certainly over the past maybe 2 decades anyway, there's been a general evolution where most physicians now are more open to kind of the team role of healthcare, something called primary care, we often call it, where both the federal and provincial governments have invested a lot of resources in that. At the same time, nurses and pharmacists can do things that they couldn't do before. There's also a group of specialized nurses called nurse practitioners. We have some in this province that can prescribe certain medications and actually help a lot of physicians out. At the same time, you know, there are still some perhaps physicians that are skeptical to that, but what I find is kind of what I call the pharmacist or nursing narcotic effect, meaning that basically a physician who's really kind of worked up close maybe with a really strong nurse or pharmacist, they can really see what they do. And if they lose that colleague, they kind of go into withdrawal. They're like, I need that kind of support back. Dr. Powell, who used to be the head of geriatrics at the Q2, he actually kind of coined that phrase. So I think generally there's still some of that going on, but it's improved a lot maybe from where we are 20 years ago. I don't know if Dr. Gray had anything to add to that, or I don't want to put you on the spot, but I know with your experience.
I think one of the biggest problems is that those of us who were educated back in the 60s, which is when I was educated, were never educated to be part of a team. The process of learning to be part of a team evolved through our own association with other health professionals. That's not true today. We have interprofessional education now for all health professionals so that they all sit down in the classrooms together. They learn their own strengths and weaknesses. They learn how they can work together. They work together on specific projects as part of their educational program. So I anticipate that will be less and less of a problem, if it is a problem at all, in the very near future, because we have addressed it very upfront in the educational programs.
The other thing that kind of supplements that too at the same time, as you know, there's right now certainly a shortage of health professionals, whether it's family physicians, nurses, or pharmacists. So we all kind of have to rely on each other to get us through this period. It's not the time really to be arguing who should do what, because there's such a shortage. You know, to really kind of need mutual help. Yeah, question.
What about the over-counter medication? Because now it is such a huge number of things. Well, this is good for arthritis. This is for this. So I think there's not any regulation, any restriction about this. And people they go, this is good. I take it. This is no harm and so. And some people they take about 10, 15 different kind of pills.
That's right.
And probably this also will probably cause some complication with the medication they are taking. I was wondering if the government or the university they put some rules and regulation for this over-the-counter medication also. Is it probably more medication is sold on the counter rather than the other medication? I was wondering if there's any thought about this regard.
Take a first crack. Good. In case for those who didn't catch it, basically the question looking at kind of, there's a lot of over-the-counter products used, and looking at maybe how do you compare how they're regulated versus prescription medications. And it's clear, yeah, there's certainly a large difference as far as the level of rigor. For a drug, a prescription medication, to be available to be sold in Canada, Health Canada has to determine it's both safe and effective. And they have kind of different ways of assessing that, but at a minimum, most drugs would have to go through at least what we call a phase 2 trial, meaning that they had to recruit patients, look for side effects, also determine whether it's working or not. So there's quite a bit of rigor as far as prescription medication coming on the market. Now, having said that, there's still problems with drugs. Certainly one that kind of stands in mind is Vioxx in recent years, right, where drugs come to the market, and sometimes the studies are not large enough to detect things that happen in large amounts. So it's not a fail-safe system. So if you compare that with over-the-counters products, certainly the level of rigor is more on the safety side. We want to make sure that they're not causing undue harm. But as far as the efficacy side, how effective they are, do they really cure all the things that they're supposed to, it's not as rigorous as what we see on the prescription side.
As a matter of fact, I wonder, like they say, this is vitamins and minerals and so on.
Yeah.
I was wondering if this really true. It is made in Timbuktu and sent here. I was wondering if there's any checkup on this. It is really true. The values they are true, or the material in this is true or not. It's just sold by probably billions of the dollars, and
That's right.
people they're buying it like crazy.
Yeah.
There's any control on this medication, or the health organization or university, they check on this, they say, oh, this is vitamins and minerals and so, is this true or not, or is it just fill in the calcium and salt and they make the billion of dollars.
Okay.
I was wondering if there's any checkup on these things.
Sure. So kind of related questions, basically, if you're buying an over-the-counter product, whether it's aspirin or a herbal product like St. John's wort, basically looking at how do we know that when you buy that bottle of aspirin, because it's not a prescription, that's actually aspirin you're getting in there. And that's certainly a fair enough question. There have been cases in Canada where, especially for herbal products, that certain researchers have gone and randomly purchased different herbal products, and pharmacies went back to their labs and did testing, and certainly found there were discrepancies between what was advertised on the bottle or the package and what they discovered in their lab. So it's certainly not as well controlled. Now, I don't want to raise panic either. I'm not saying it's always the case, but certainly for over-the-counter products, again, it's not as tightly controlled as a prescription product.
I think the government should have rules and regulation and have checkup on this material before they put on the shelf.
Actually, the Canadian system is better than the American system for those kinds of things. It's one example where Canada has actually led. The American system for prescription drugs is reasonably good, but for non-prescription drugs, including herbal medicines and so on, the onus now is on the government to demonstrate that these products are unsafe rather than that they're safe. So the product can be sold, and it's only when there's a whole host of problems that the government can actually intervene. In Canada, on the other hand, the legislation requires that the manufacturing process be carefully overseen before the product is actually released into the Canadian market. Now, that's a relatively new introduction, and so they haven't yet implemented it right across the entire field, but it's gradually rolling out, and probably by about 2010, they'll have almost all the manufacturers of herbal medications and over-the-counter medications under the purview of Health Canada.
The other kind of one point as well to add to that, many of our over-the-counter products are made by the same companies that make the prescription products, often the same facilities as well. So at least we kind of have that check as well, that it's generally, whether it's aspirin or ibuprofen, they're made, again, by the large companies that make the other products as well.
I was wondering if this over-counter is all made by the respectful pharmaceutical company, or just coming from, as you have.
That's right. Yeah, there are some maybe herbal products that do come from smaller companies, from foreign, but probably the majority of kind of your most common, maybe 10 or 20 over-the-counter products would be by reputable companies that also make the prescription products as well.
But that all of them, they come from China.
No, certainly not. No, that's not the case. All our toys come from China, right? Yeah, right.
I'm just curious about the extent of the medication review you're talking about. Someone goes in to see a pharmacist and they have a whole bunch of prescriptions. The pharmacist can't prescribe.
Yeah.
So what advice do you get from a pharmacist to go back to the physician and talk about these drugs? I mean, what is the extent of the medication review?
Sure. So for those of you who have not experienced a medication review, what does it look like? And certainly, it's not a uniform thing, so it might look a little different in, say, a Lawton's versus a Shoppers versus a pharmacy. But in general, the pharmacist would want you to bring in all your medications. They would also do a printout of your medications and just look and see generally, are there, maybe you're on 3 medications for this condition, they might be interacting. And so certainly if it's a more urgent thing, they might call the doctor with your permission on your behalf and see about a change. But generally, if it's something, they might just say, next time you see your doctor, here's some information. And you're right. I mean, that's kind of going back to Glenn's question about the turf battles and not stepping on toes. Most pharmacists are, they're going to be very conscientious of not replacing the doctor, but on the other hand, there are a lot of people on a lot of different medications. And again, as we showed, it's not just the same doctor prescribing them. So often your family physician may not know actually what the different specialists have prescribed. So that's really the role of the medication review. So as I mentioned, Ontario government's actually, they have a pot of $50 million a year that they're paying the pharmacists $50 to do them with complex patients. In Nova Scotia, we just started a small pilot with the government in Truro, one part of Cape Breton. But the idea, the government obviously, they see the kind of the need for it. That it's not for everyone. Just like when you go to the dentist, when people go to the dentist, if you ask the average dentist what their day's like, probably 90% are people in for the typical cleaning and maintenance. Maybe 10% are there for the root canal. It's probably like that with the medication reviews. Not for everyone, but if you're on a lot of complex medications, it's probably a good worth of your time, good value.
There's actually been a pilot project in Southern Ontario where they have had pharmacists introduced right into clinics where there may be anywhere between 8 and 12 family docs practicing. And the pharmacists are actually available there to do continuous medication review, to work with the patients, to work with the physicians. It's being very rigorously evaluated to see whether or not it will both reduce error and possibly even reduce costs, even though there's obviously a cost associated with incorporating the pharmacist into practice. And although it's still early days, it's only about 5 years old, the initial results are actually quite promising. And I think they're promising enough that the government are actually planning to extend that project. So we may yet see a time when physicians and pharmacists will be practicing in a very collaborative fashion.
Maybe just one more question.
Oh, sure, yeah.
Who in the health profession is really on, is it the pharmacist that's more on top of kind of the new medications that are coming out, the medications that are more available? Are they kind of more on top of that in general than a physician would be?
The drug reps would be.
But the drug reps are the pharmacists.
Well, I'm going to answer that because it's an area that I've been quite caught under the collar about. I'm a physician, I'm not a pharmacist. I'm a pharmacologist by training, but that simply means that I spend a lot of time in the lab. Quite frankly, the answer is yes, the pharmacist is the better informed these days, because I don't think that the appropriate education has been given to medical students, and I say that knowing full well that I've been part of that educational process. The reality is that there have been so many pressures to introduce so much into the medical school curriculum without lengthening it, that there has been a major dilution of the kind of education that the students are getting about prescribing, and they're getting it on the job at the present moment rather than from their educational process. On the other side, because I've taught both medical students and pharmacy students, the pharmacy students get a very solid education.
Yeah, I would echo in one piece maybe to add that even just one thing, even physician knowledge about the drugs and their side effects, but the aspect about how much they cost, that's even worse in that most physicians aren't so familiar about, how much does a drug actually cost if the patient goes and gets it filled up in the pharmacy. So that's, that can be a challenge, because often there's maybe 5 or 6 drugs that maybe are about the same as far as how they work, but we know that maybe 2 of them cost less, and yet a lot of physicians don't know about the cost aspect as well.